Welcome to Module 4 of our Wound Care Certification Program, Factors Affecting Wound Healing. Wound healing is not just a biological event. It's a deeply personal, clinical, and environmental process. Whether wounds progress smoothly or stall depends on a complex interplay of internal and external influences. As nurses, your role is pivotal in identifying barriers and creating conditions for optimal recovery. Let's explore how. By the end of this module, you'll be able to distinguish between intrinsic, extrinsic, and wound-specific factors that influence healing, understand pathophysiological mechanisms that delay recovery, conduct comprehensive risk assessments using validated tools, implement tailored nursing interventions to overcome modifiable barriers. This knowledge will empower you to move beyond routine care toward strategic, patient-centered wound management. Wound healing follows a predictable sequence: hemostasis, inflammation, proliferation, and remodeling. But real-life recovery is rarely that simple. Factors like poor circulation, infections, malnutrition, or inappropriate dressings can halt this progression and result in chronic, non-healing wounds. In this module, we'll unpack these factors and their clinical implications. Because when you understand what's impeding healing, you can intervene with purpose. Let's start with intrinsic factors, those that originate within the patient. These internal conditions may not always be modifiable, but their effects can be managed with informed care. Advanced age. With age, the skin becomes thinner, less elastic, and slower to regenerate. Older adults also experience reduced immune response and vascularity, leading to delayed healing and increased susceptibility to pressure injuries and skin tears. Chronic illness. Conditions like diabetes impair circulation and immune function. Peripheral vascular disease, heart failure, renal disease, and COPD all reduce tissue oxygenation and nutrient delivery, two essentials for healing. Malnutrition, deficiencies in protein, zinc, vitamin C, and iron slow collagen production and cell repair. Always screen at-risk patients using tools like the Malnutrition Screening Tool, MST, and involve dietitians early. Let's explore more patient-related barriers. Obesity. Adipose tissue is poorly vascularized, making it harder to deliver oxygen and nutrients. Skin folds increase moisture retention and risk of infection, while excess weight adds pressure and shear. Medications. Some drugs can interfere with healing. Corticosteroids suppress inflammation and collagen synthesis. Chemotherapy slows down cell division. Anticoagulants increase bleeding risks. Immunosuppressants lower resistance to infection. Smoking. Nicotine causes vasoconstriction, which starves wounds of oxygen. It impairs fibroblast proliferation and slows angiogenesis, making even minor wounds harder to heal. The takeaway? Intrinsic factors must be considered in every care plan, because healing begins with understanding the whole patient. Now, let's look at extrinsic factors, those outside the body but within our control. Pressure, shear, and friction. These mechanical forces reduce blood flow and cause tissue ischemia, especially over bony areas like heels and sacrum. Turn patients every 2 hours and use pressure-relieving surfaces to reduce risk. Moisture imbalance. Too much moisture from incontinence, sweat, or exudate can macerate skin. Too little moisture dries out the wound bed and slows epithelial migration. The goal? Maintain a moisture-balanced environment for optimal healing. Infection and biofilm. Infection delays all phases of healing and destroys healthy tissue. Biofilms form a protective barrier over bacteria, making them harder to treat. If a wound isn't healing after 2 to 4 weeks, culture it and consider antimicrobial interventions. Let's dive deeper into external influences that can delay healing. Inappropriate wound care. Too many dressing changes can damage new tissue. Using the wrong dressing, like dry gauze on a moist granulating wound, can set healing back. Failing to debride necrotic tissue creates an environment where bacteria thrive. Every dressing and debridement decision should align with the wound's current phase, temperature and oxygen tension. Even a small drop in wound temperature can cause vasoconstriction and slow enzyme activity. Hypothermia reduces perfusion, so does hypoxia, especially in patients with anemia or arterial disease. Low oxygen impairs leukocyte function and collagen production, making wounds more vulnerable to infection and breakdown. Wound-specific characteristics also shape the healing journey. Size and depth. Larger, deeper wounds take longer to heal. They may need advanced therapies like NPWT or skin grafts to promote closure. Exudate. Some fluid is normal, especially during the inflammatory and proliferative phases, but heavy, foul, or purulent discharge could mean infection or poor moisture control. Location. Wounds on the feet or hands, areas with less blood flow, heal more slowly. Wounds over joints or high motion areas may reopen or resist epithelial bridging. Wound edges. Rolled or undermined edges indicate stalled healing. Irregularly shaped wounds are harder to contract and close. Tissue type. Granulation. Tissue is red, moist, and a sign of healthy healing. Slough is yellow, non-viable tissue that must be removed. Eschar, especially on heel ulcers, may need conservative management if stable, or removal if infected. Each of these details should guide your dressing choices, interventions, and expectations for recovery. To manage these variables effectively, you need the right tools. The Braden scale helps identify patients at risk for pressure injuries by assessing mobility, nutrition, and sensory perception. The Malnutrition Screening Tool, MST, flags those at nutritional risk, prompting early dietitian involvement. The Wound Healing Index, WHI, estimates healing potential based on wound type and comorbidities. And don't forget the time framework: tissue, infection, stain, inflammation, moisture, and edge. It guides structured wound assessment and ensures you're addressing all dimensions of healing. Standardized tools create consistent care, and consistent care leads to better outcomes. To wrap up, wound healing isn't just about biology. It's about the person, their condition, their care environment, and the choices we make as clinicians. Each wound is different, and each patient has unique challenges. But with clinical knowledge and critical thinking, nurses can guide recovery. When we understand intrinsic, extrinsic, and wound-specific barriers, we don't just treat, we heal. We don't just react, we prevent. And we don't just follow orders, we lead care that transforms lives. Thank you for your commitment to learning and to healing.